to ask you about that. I'm really curious about that surgery you just talked takes about 6 minutes. I think that the idea of a surgery taking 6 minutes that cures a pain that may or may not be, is this a common pain?
Oh my God. It affects about, depending on the study, anywhere between 3 and 7% of the population. It's a pinched nerve in the wrist. People think it's from typing and use, and that is a complete myth. Again, something I haven't been able to get. I spoke to 60 Minutes about this about 28 years ago. I'll never forget. They told me it wasn't sexy enough. I said, people think carpal tunnel syndrome is that computer disease. That is a complete myth. So without going into, we don't have time to go into the causes. It's a metabolic and hormonal phenomenon.
So is this what you're calling carpal tunnel?
Carpal tunnel syndrome. And it's a syndrome because it's a constellation of symptoms. And the main symptom is the hand goes numb and gets tingly. And typically.
Hi, I'm Zane Myers, and this is the Trustcast Show, where we interview leaders in business, health, law, and finance. So welcome to another episode of the Trustcast Show, and I'm here with Dr. Badia. So did I pronounce that right?
Badia.
My
first name's harder.
That. Dr. Badia,
yes,
who is a hand and upper limb surgical specialist.
Right. Here to here.
And you, so from where to where?
So from the fingertip to the shoulder, including the clavicle.
And then the name of your practice is the Miami Shoulder Institute. Is that right?
No, actually, we started that with my first partner I've had in the past 18 years. We started that as a patient education and marketing portal, but the practice is called Badia Hand to Shoulder Center in Miami.
Okay. So tell me about how you ended up in hand surgery. I mean, and shoulder surgery. I mean, shoulder surgery. I'm also a tennis player, and shoulder surgery is notorious for getting right. So even finding somebody who specializes in this whole from the hand to the shoulder is just difficult to find somebody who does that, has experience, and has a successful practice. How did you end up?
Yeah, that's why it's important, for patient education. So I ended up in this because, let me start that I'm an immigrant. So I was born in Cuba, went to public school in New Jersey, and like many immigrants, my parents had to work. I was very, very young, and my paternal grandparents from Valencia, Spain, raised me those few years, like while my parents worked, and my dad went to engineering school, nights, typical track. And she had really horrific rheumatoid arthritis. And I remember that. And in fact, when I was 8 years old, so I'm spilling the beans because I discussed this in the first chapter of my book that I wrote called Healthcare from the Trenches. But in the first few pages, I say that we went to see a hand surgeon when I was 8 years old. And decades later, I figured out that it was Bob Carroll at Columbia University in New York. There were very few hand surgeons in the 70s. And I was really inspired from that moment on. So I won't say that I knew as a 10-year-old I was going to be a hand surgeon. But once I was in medical school at NYU and then my residency, I got interested in orthopedic surgery because it's a specialty of, function, resolving pain, but also function, which is really the hallmark of hand surgery, right? I mean, foot and ankle surgery or, knee surgery for athletes, everybody talks about this, but you can function with a bad knee. You really can't function very well without a hand. So I gravitated towards that specialty and trained it in New York for a decade, then went to Pittsburgh, Germany, and then I've been in Miami 30 years, and I co-founded the Miami Hand Center, which grew to a group of 5 surgeons, which disbanded. Everybody went their separate way about 18 years ago, and then I started my own practice, and here we are.
So I'm gonna. So this is some of my research. The volar locked plate technique for distal radius fractures.
That's right.
So tell me about that. The notes that I have says transform wrist surgery worldwide. Is this your idea? And how did this come about? How did you become an expert in this
Yeah.
particular area?
So no, like
And what
many
is it?
great ideas, it's often with collaboration. The colleague who before me, when I joined them, I coined the phrase and even the logo of the Miami Hand Center, which was 30 years ago. But between the two of us, we realized that literally the most common adult fracture that needs surgery is the distal radius. When people fall, they typically break their wrist. So there's a bimodal distribution, meaning you see it in kids, but they rarely need surgery. But in adults, if it's a significant fracture, most do. And it's very common. I mean, extremely common fracture. So we basically took what was the world's most commonly operated fracture and turned it on its head. When I joined my colleague, he was putting external fixator. It's like an external bar, looks like a torture
Mm-hmm.
device, and that was very common. And then people started plating them, meaning opening, fixing the bone, and plating it. That's a concept called ORIF, open reduction internal fixation, right? Fixation with plates and screws. But most people were doing it on the top, based upon the fracture pattern. So not to get too technical, we basically said it's much easier and better to put the plate on the bottom side. And now it's a worldwide standard. So it's pretty interesting. You know, I've been to 3 meetings in the last few months, and typically in the hand surgery world, the topic of distal radius fractures comes up, and it's very for me impactful and touching to see, you know, somebody from Japan or Australia or, you know, Eastern Europe talking about this fracture, because I know that I had a big hand, no pun intended, hand in changing the way that's treated.
So are there still people that come with the plating on top, or is this still an educational thing, or has this just
It's a good
become the
question.
standard?
The technique it's become so much a standard of care that now there's always, you know, contrarians who say, well, certain fractures, you should put the plate on the dorsum on the top. So yeah, it does happen. On rare occasion, I've done that, but yeah, no, I mean, I've been doing it the way I'm speaking for more than 25 years.
So what was the result of somebody who had the plating on top? So must have been a reason why you decided, well, this is BS. This other way is not working right. What was the result of what happened between those, and how did you decide? Okay, well, I'm going to do something completely different.
Well, there's very technical reasons, but in summary, the bone on the top is very soft. That's why typically when you fall, the bone goes backwards, because the bone on the top, on the dorsum, is very soft. The bone on the bottom side is very hard, what we call cortical bone. So it's much easier to restore the anatomy on the thick bone rather than try to do the jigsaw puzzle. And the tendons are very close to the skin and right over the bone. Whereas here, it's much deeper. So you really almost never have problems with the plate related to any impingement, it's, you know, tendon irritation, etc. So there are very technical reasons, but it's like many inventions, right? It's a matter of simply being open-minded, and taking something that wasn't completely new. People were occasionally putting plates here, but for certain fracture patterns, we basically said we can use it for virtually every fracture pattern because it is better for some of the reasons I alluded to.
So you said younger patients don't usually, they usually will heal on their own. So the older patients, like someone in a senior center or anybody after 40, or what's kind of the determination there?
Any skeletally mature adults. So, you know, even in the late teens, we occasionally will plate, but in younger patients. So just 2 days ago, I had a 14-year-old. The growth plates were still open, meaning he was still, you know, young adolescent male. And I was able to numb up the area and pull and do what we call a closed reduction. that doesn't work very well in adults because inside the cast, the fracture will tend to settle because the bone is soft. They don't have the membrane like children do, called the periosteum, which is very thick. So there's a lot of technical reasons. Bottom line is, when a patient has a fracture, they really should seek out the appropriate subspecialist. It's almost impossible nowadays in orthopedics or any surgical field to be expert in everything. So I haven't done foot and ankle surgery in 30 plus years. Certainly not spine surgery. Not that's the point. So I think the lesson for the public is to understand you really want to find the person who really focuses on that area.
So let me ask you about, since I'm a tennis player.
Yeah.
And I know at least one tennis player that I know was really exceptional player, and he played with his right-handed, and his shoulder went out, and he had some surgery. It didn't work out, and then he started playing left-handed, and he got to be really, really good playing left-handed. I mean, this was incredible, and his other shoulder went out. He quit playing tennis altogether. But so I know that so many people have a difficult time with their shoulders, and it's really hard to find someone who is, a subspecialist in that area that has a lot of successful work behind him. So can you tell me a little bit about your practice and that specific area? What do you do that's maybe different or?
Well, people often will make mention that they or somebody they know had a particular surgery, it didn't go well. The problem is that's not enough information, right? It's always worth in medicine to get a second opinion. Maybe they had a problem that unfortunately doesn't have a great solution. So I don't know. The point being is that if you see somebody who does something enough over the years, you get much better. So it's always worth getting an opinion. So I have a particular interest in tennis medicine. In fact, last year an article came out nationally about that I wrote about the most common pickleball injuries. And even though I've only played pickleball once and on a hotel rooftop in Mexico City, but I do play. I started playing tennis about 12 years ago because I do treat many elite players, and I don't want to mention names because that can be sensitive. But that is one of my niches in healthcare is actually athletic injuries of the upper limb. So in tennis, for example, if you're a bit older, typically there are rotator cuff problems because there are degenerative issues that come with age, so to speak. And I've actually had both of my shoulders scoped, and I am playing tennis now. So it's just a matter of making sure you find the right person. But there are a host of problems, and I've written articles about that, and you can find that on my website, drbadia.com. I have specific articles that I've written for patients because I do feel that us physicians write a lot of, and I do the same. I write clinical and scientific articles, but they're not read by patients. So I think it's important to put the terms in and educate patients about these problems because they're the end user, right? Ultimately, they're the ones going to benefit. So I really like to write, and I can probably think off the top of my head of about 15 to 20 articles that have been published. Unfortunately, actually one was in U.S. News and World Report, but I can tell you that what people read, right? The New York Times and Washington Post or these publications, you often don't see, unfortunately, articles about really common medical problems in those publications. They're often very focused on, plastic surgery and now obesity medicine. And I think it's important that popular media engage with us as physicians who want to educate the public. So the answer about your tennis friend is, and I do a lot of telemedicine. So I've been doing it well before the pandemic. I use Zoom Health, and it's very easy to examine somebody remotely. Okay, there's certain things I can do, and then I can look at their imaging study, which in the shoulder invariably needs an MRI, and we can come up with a plan. And that's about 40% of my practice is people who fly in, some domestically, but I would say the majority come from abroad. I had a pro tennis player from Australia, for example, who I operated on his wrist. He was so happy with that. He stayed in Miami, and I fixed his labrum about 2 weeks after that. So he went back to Australia with that, and he was back on the tour in about 3 months. So
wow.
yeah, there are there is hope for these things.
So obviously, younger guy, not an older guy like us.
Right. Well, yeah, he was a younger guy, absolutely. But look, one of the I'll give you a good example. Massive rotator cuff tear in a lady who's actually a neurologist. Her son was a ranked tennis player, and I had fixed his wrist 20 something years ago. And she came to me, and she was, she's considerably older than I am, and she plays tennis vigorously as a hobby. And she went back after she surprised even me. So there definitely is hope.
So talk to me a little bit about non-invasive types of procedures. And I mean, do some people come to you and say, Doc, I need a surgery of this kind, and then you say, well, let's look at this. Maybe you don't. And what are some of the alternatives if that's the case?
Well, sure. Well, for one, unless they have a really significant anatomic lesion, okay. So if you have, say, a partial rotator cuff tear, we always start with conservative measures. I do think that trying to obtain some at least partial healing and then followed by therapy is more beneficial than just going to therapy. But certainly therapy for the shoulder is critical, and I collaborate very much with my therapy colleagues, not just here but abroad. Because when somebody comes to me from a tennis player from, say, Lima, Peru, or I'll just throw out his name because he's been very public, but there's a tennis player named Lapenti from Ecuador, right? He was number 6 in the world, his brother. I mean, I will communicate with the therapist in Ecuador, in Guayaquil, Ecuador, directly, because we have to be partners in the care. So if a patient comes to me, I will, as long as it's not something really significant or they failed conservative treatment, we always start with that. And typically what I may offer is an injection of PRP, which are platelets. It's your own blood, right? It promotes healing. But I like even more powerful at are growth factors that are off the shelf, that come from tissue, and it's very powerful. And I inject that under ultrasound control. Patients barely even feel it. It does not hurt. Patients are afraid. I can tell you from experience, it does not hurt. And then occasionally there are patients who come in and say, you know what, I want my own stem cells. It's more expensive. It's more it's a little more effort, but we do some fat-derived stem cells, meaning we go to the abdomen. So that's kind of nice. You get a little bit of a tummy, a little bit of a liposuction, and I take some fat from the abdomen. We put it through a process, and then we inject those fat-derived stem cells into the shoulder, or occasionally the wrist or the elbow. So there are many options before we discuss surgery, for sure.
So the PRP, the growth factor. So I'm familiar with PRP, but just for people who don't know what that is, Can you talk a little bit about that?
Sure. So imagine when you have a little cut in your skin, right? The area gets red. That means the blood vessels come in. What happens is in the blood, in the capillaries, they're there to help heal a wound, and they dilate. They bring in more blood. That's why the wound gets red. And in the blood, the red blood cells carry the oxygen, the hemoglobin, but they don't have healing properties. The healing actually comes from the plasma, which is the, let's say, the clear to yellowish component of blood that has so many growth factors that I couldn't name them. We're talking 30 to 40 growth factors that heal wounds. So what we do is we take your blood. We usually take 10 cc's of blood in the office. We put it in a centrifuge. We spin it. The heavy red blood cells go to the bottom. The top is a straw-colored fluid, and that is the plasma. And then we take the plasma and we inject that into the painful area, injured area, what have you. So every time I do a surgery, like yesterday, I did a massive rotator cuff repair, very big. So I do the repair, and then before we put the dressing on, I take a little needle and I put their own plasma between the rotator cuff and the bone that I reattached, and that will further stimulate healing. So these are things that we actually do routinely that a lot of times patients aren't even completely aware of, other than we tell them, when we put your IV in for surgery, we're going to also take some of that blood, spin it down, and help you to heal. So these are all really common things.
So it's like almost like a standard procedure when you have a major surgery. You do that because the effect of the healing is
exactly. Oh, it's. I mean, I would hazard to say it's pretty standard amongst in a lot of centers, but certainly I've been doing it that way for 20 years. So we do use what we call orthobiologics. Now, unfortunately, the whole PRP and stem cells starts getting routed to the thing everybody's interested in, right? Is aesthetics. So injecting, plasma, for wrinkles and for hair growth. And granted, I mean, look, I live in Miami, right? People, here really care about looks, but let me tell you, as you know, Zane, when your buddy who's got a shoulder problem and has to change arms playing tennis, it's pretty important. So I think that some of these issues should be discussed more in popular media because patients really benefit.
So, so you mentioned two other things. One was the stem cell,
yes,
and one was growth factor. How do those? How do you make a determination as to what particular route that you're going to take?
Yeah, well, like many things, unfortunately, it's partly dependent on cost, right? I mean, understandably, people want to use their insurance, but what you have to understand, and I'm going to be very, very blunt about this, your health insurance company really doesn't care very much about you, okay? They are there to collect premiums and make money, and that's fine. I'm a capitalist. I came from a communist country. I think it's great that insurance companies make money, but not at the expense of providing the care they should. So, unfortunately, even though there is good evidence for a lot of these biologics, most insurance carriers don't cover them. So it's beholden on the patient to make the decision: is my shoulder pain worth me, spending the money for instead of that holiday weekend somewhere? That is a personal decision. The growth factors off the shelf are a bit more expensive because they come from actually umbilical and placental tissue and has to be processed. It's a pretty significant process. In fact, I visited the lab of the one that I happen to use. And then the stem cells is just more of a process. I mean, it's actually like a 30-minute procedure. There's equipment with it, so that's going to be a more expensive. So it's really up to the patient. I recommend the PRP if it's a more minor thing, because I don't think they need to spend money on the more potent, right? Although some patients come in and say, doc, I want the best solution. I want to pay to get, and then at that point that allows us to practice medicine in really the optimal way, is giving them the best solution.
So I've seen that you've trained surgeons all over the world.
Yeah, and well, I learned from them too. But yes, I have. We've had a fellowship for decades now.
So when they come in or when they leave, what do you hope is the main thing that they take away?
A few things. I think the most interesting thing that they don't realize when they come is they're actually going to learn a lot about how to practice orthopedic surgery, how to run the office, how to bring in the biologics we mentioned, how to have that you can have all facets of care under one roof. So I haven't done surgery in a hospital for 15 years until last month. I did one case, a shoulder replacement, because he's one of my best friends and he wants to go back to playing golf. He's in his 70s, but he has a defibrillator, and our anesthesiologist thought it wasn't safe. That's another issue. The reality is he did great. He's in phenomenal shape. But that was the first case I've done in 15 years in a hospital. So what I think the visiting fellows from other countries is the U.S. is well ahead in the concept of outpatient surgery and independent ambulatory surgery centers. So when a patient comes to my office, MIA, Miami International Airport's literally about 11 minutes away. They come into my office, they can have x-ray, ultrasound, even MRI in my office, Badia Hand to Shoulder and Miami Shoulder Institute. And then the surgery is down the hall in an independent ASC where the anesthesiologist will do a block that many of the hospitals don't do with Exparel, which is a medication that provides pain relief for 2 to 3 days. Okay, a lot of hospitals won't do that because it costs too much,
Right.
so, which I think is absurd. The surgery is done, the patients go, either home to a hotel, maybe I have an apartment or a friend in the Miami area, and then I see them a few days later for post-op. We even do therapy down the other hall. So everything's in one place, and I think the visiting fellows are kind of blown away that they're used to in their countries, whether I've had fellows from, I had somebody from Pakistan recently, or Australia, or Spain, or Brazil. In those places, pretty much healthcare is delivered in hospitals, and I think hospitals are very expensive. So
yes,
I think that we're starting to see that transition, but I think that's what they learn. The other thing they come is I'm known for arthroscopy, so certainly we keep talking about shoulder, but one of the things I'm very known for is wrist arthroscopy. So that means that you can go into this joint with a 2.4 millimeter camera, see it on a 40-inch monitor, and identify the pathology much better than MRI, but then also treat it. So it's a diagnostic and therapeutic surgery that's minimally invasive. Not a single stitch is used. And so I think a lot of the fellows come. Now, they don't get to operate. Years ago, they did. I mean, they weren't responsible, of course, but they at least could help me. And unfortunately, our legal system has really hurt healthcare in so many ways. So these folks, they learn by observing, which is still very good for them. But it was nice when they used to be able to actually scrub and assist me in surgery.
Right. I can understand that. My son is a podiatrist.
Ah, okay.
So he just, and he's a resident. And so the idea of being able to actually assist and do the procedures and, if you can't do it, you miss out on a lot of the process.
Yeah, absolutely. Absolutely.
Becoming an expert.
Well, most of the people who come visit are trained surgeons. So look, I went to visit a colleague in Connecticut for a particular open shoulder surgery. I don't do a lot of it. We had a mutual patient who's a world contender boxer, middleweight guy. And not to get too technical, but he does a technique that I do, but I'm not as experienced. And I said, this guy is a potential world champ. So I ended up meeting my patient and his trainer and his manager up in Connecticut. And in that case, I was allowed to scrub. So I didn't do anything manual, but scrubbing allows me to get into the wound and really see and say, oh, okay, Paul, I like this. I like this technique that you're doing, and now I know. And in fact, 2 weeks later, I did the same in Miami. So we're always learning in medicine, whether you are in training like your son or you're 30 years in practice. You always want to learn, and that's, I think, one of the really fun things about medicine.
So I'm going to shift gears just a little bit, but I want to ask you about your marketing.
Yeah.
So how do you do? What kind of marketing do you do, and what kind of a time drain is that? Is it frustrating? Is there some rewarding parts of it? Just tell me a little. Maybe if you can talk a little bit about, because I talk to a lot of different doctors, and some of them, nobody really seems to like it, but some of them do better at it than others. Maybe you can just talk a little bit about that.
Sure. No, I actually enjoy it. The only frustrating part for me is I will fully admit that I'm not often the best manager, and a good manager knows how to assign tasks and follow up with them. And I often kind of assume it's being done, and that's really not good. So those are things I need to work on. But the nitty gritty of healthcare marketing, I enjoy because I like to teach and I like patient education. And one of the reasons is that I hate to hear stories like your friend who has a shoulder problem and then decides to play tennis with the opposite arm because he didn't find a solution. So to me, those patients come to my office and I say, wow, if we had only done a better job educating them. So I look at marketing more in the healthcare realm as education. So as you educate the patient, then they learn. Certainly, they may decide, hey, I'm going to make the effort and go to Miami, which is not the worst place in the winter, right? And I'm going to go to Miami and stay there for a few days and have Dr. Badia at least assess me and maybe, do an indicated procedure. But that doesn't always happen. In the end, what healthcare marketing does is it really elevates, all ships rise in a tide. So many of my colleagues may benefit from this. So I enjoy that. It's a multi-pronged approach. I just gave actually a lecture on this at the American Society for Surgery of the Hand, right? It's the biggest hand surgery organization in the world. And the meeting was in Vancouver about 3 weeks ago. And I spoke about social media now gives us a great tool, right? Because it's basically free. Now, as you alluded to, it takes time. So you have to want to do that. I don't think I'm very funny. I wish I was. Some of these people are funny and that's the way they teach. But I tend to be more factual and I try to make it interesting. But there are multiple platforms, right? There is, I've gotten more involved with Instagram over the last few years. Because a lot of athletes follow it, right? So my tennis players, Facebook ends up being more our generation, right? Kind of older patients. So that's important. Facebook. And then there are videos on YouTube. I do live surgery every 2 weeks. So on Tuesday coming up, I will do something called #LiveSurgeryTuesday. And while it's directed a little more at fellow surgeons, a lot of patients will watch. And they want to know, hey, how do you do a carpal tunnel release endoscopically? That was the last one I did. And patients were like, wow, I can't believe how easy that was. Why am I suffering with numbness and pain in my hand at night that wakes me up? I can have a surgery that takes about 6 minutes that cures it. So that education it really has a downstream impact of making people better. And ultimately, that's why we go into medicine. We want to make people better.
So I wanted to ask you about that. I'm really curious about that surgery you just talked takes about 6 minutes. I think that the idea of a surgery taking 6 minutes that cures a pain that may or may not be, is this a common pain?
Oh my God. It affects about, depending on the study, anywhere between 3 and 7% of the population. It's a pinched nerve in the wrist. People think it's from typing and use, and that is a complete myth. Again, something I haven't been able to get. I spoke to 60 Minutes about this about 28 years ago. I'll never forget. They told me it wasn't sexy enough. I said, people think carpal tunnel syndrome is that computer disease. That is a complete myth. So without going into, we don't have time to go into the causes. It's a metabolic and hormonal phenomenon.
So is this what you're calling carpal tunnel?
Carpal tunnel syndrome. And it's a syndrome because it's a constellation of symptoms. And the main symptom is the hand goes numb and gets tingly. And typically wakes people at night because there's fluid retention at night. So what we do to release it is simply unpinch the nerve. Now, traditionally, people have done an open incision, which works great, but you're a little more sore. It takes a little while for your friends to go back to tennis or golf or back to an office job. It may take, a week or two, not a long time. But when we do it, using the mouse, right? But that has nothing to do with a pinched nerve. That's the point I'm trying to make. The other technique, which has become more and more popular over the years, is endoscopic release. Meaning, just like nowadays, my colleagues take out a gallbladder with 1 or 2 little holes. There's no reason to open somebody. We go in with a little scope. So I mentioned before wrist arthroscopy. That's a joint. The carpal tunnel is not a joint. It's an anatomic tunnel where 9 tendons, flexor tendons, run in this tunnel, and one nerve called the median nerve. The nerve is pinched. So when I divide the ligament, that's the roof of the tunnel, it springs open, and the nerve is no longer pinched. It's that simple.
And it takes minutes.
Yeah.
And this, because I see people, I just think of one. I used to work in medicine. I saw it. I remember this one particular, somebody worked in a purchasing department, and she had this wrist thing on, and she was always in pain. And I got this carpal tunnel. There's no solution for it. I've been to all these doctors. I just exist in pain all the time. That's the way it is.
Well, Zane, let me comment on that, because personality has a lot to do with things. Okay. I have noticed, and us hand surgeons know, when somebody walks into our office, with like this, sometimes people use this as a bit of a crutch. I certainly believe that it's a very common condition, but it does have a solution. So granted, she may not have seen, when people say, oh, I went to the doctor, I say, well, what type of doctor? Because I'm a doctor, but I don't know anything about the eye. And I was an ER physician in New York to make ends meet as a resident. But I honestly know nothing about the eye. So, when you say, when that lady said she went to multiple doctors, I'm thinking, my first question would be like, well, wait, did you see a hand specialist? Because a hand surgeon, if indeed that's the problem. Now, sometimes there are other issues that can be related. Okay. But it's important to have a careful physical exam by a specialist. And many times nerve compression will come along with what we call trigger finger, which is a tendonitis. It's very painful. You can't close, and the finger actually gets stuck, most typically the ring finger. Right. There's a type of tendonitis in the wrist called Decker veins. There is something called basal joint arthritis at the base of the thumb, which I'm known for in the U.S. because I'm one of the few American surgeons that really believes in doing an implant or replacement surgery, which is now common in Europe. And I've been doing it in the U.S. for over 25 years. So there are a host of things that this person may have been suffering from. But this thing where there's nothing they can do, that, I'm sorry, but that's pretty rare. I mean, unfortunately, I leave that for my oncology friends. There are, still people, unfortunately, that pass away from malignancies, and I'm hoping, basic science will change that. But at least in the upper limb, for the most part, we can get people a lot better.
Thanks so much for tuning in today. If you have a suggestion for a guest for our show, email us at support@trustcastshow.com, and we'll get the conversation started.